All right, everyone, let's dive into a topic that is absolutely critical for your NCLEX and, more importantly, for your future practice. We're talking about infections in pregnancy. This is stuff you will see, you will manage, and you need to know it cold. So let's get you prepped.
So here's our game plan for today. We'll start with why pregnancy makes someone more vulnerable to infection. Then we'll walk through the all-important screening timeline. After that, we'll hit the major STIs, tackle Group B strep, decode torch infections, and wrap it all up with a super high-yield NCLEX review.
Okay, Section 1, Pregnancy's Infection Vulnerability. Let's get right to the core of why this all matters so much. Pregnancy literally changes the body's immune system, and when that happens, you're suddenly protecting 2 lives, not just 1.
And I want you to think about this question for a second. How can a bacterium that's incredibly common, one that often causes 0 symptoms, suddenly turn into a life-or-death situation for a brand new baby? It seems like a paradox, right? Well, this is exactly where nursing, where you become so incredibly critical. Here's the bottom line. The amazing physiological changes that help support and grow a fetus can, ironically, also make the pregnant client more susceptible to infections. The stakes are incredibly high for both of them, which is why early and consistent screening isn't just a nice-to-have, it is the absolute standard of care. It's everything.
So that brings us right to Section 2. The prenatal screening timeline. You see, knowing the why is important, but for the NCLEX and for safe practice, you have got to know the when. Let's break down the schedule.
And you have to realize this timeline is super strategic. It's not random. Right at that very first prenatal visit, bam, we are screening for the big ones: syphilis, Hep B, HIV, gonorrhea, and chlamydia. We need that baseline. Then you fast forward all the way to the 3rd trimester, right around 36 to 37 weeks. Now the focus shifts entirely to Group B strep, or GBS. Why then? Because its presence right before delivery is what poses the risk to the baby. And of course, for any clients considered high risk, we'll repeat those STI and HIV tests then too.
Okay, lean in for this one. This is a huge, huge NCLEX tip. You are absolutely going to get questions on this timeline. Knowing the difference between what we screen for at the first visit versus what we screen for in the 3rd trimester, it's a guaranteed point on your exam. Don't leave it on the table.
All right, let's move into Section 3, Major Sexually Transmitted Infections. We're going to dive deep into HIV, gonorrhea, chlamydia, and syphilis because they all require really precise management during pregnancy. And we're going to start with HIV. When it comes to preventing mother-to-child HIV transmission, it is all about a strict multi-step protocol. You have to know these 4 steps. 1. The client starts antiretroviral therapy, or ART, during pregnancy to get their viral load as low as possible. 2. During labor, they get IV zidovudine. 3. After the baby is born, the newborn gets zidovudine for up to 6 weeks. And 4, a critical patient teaching point here in the US, you have to counsel the client to avoid breastfeeding because the virus can be transmitted that way.
So let's apply that right now with a little NCLEX challenge. Your laboring client has HIV. Look at this list. Which of these interventions are absolutely contraindicated? Take a second, think about the route of transmission, and make your picks.
Okay, you got your answers? The correct ones are A, C, and E. And the rationale is actually super simple once you think about it. A vacuum extractor, forceps, an internal fetal monitor. What do they all have in common? They're invasive. They can break the baby's skin, which creates a potential pathway for exposure to maternal blood. We have to avoid that. Now, oxytocin is perfectly safe. And a C-section? That's actually often recommended, especially if the client's viral load is high, meaning over 1,000 copies per milliliter.
Okay, here's a quick hitter summary table for you. For chlamydia, remember, it's often asymptomatic, that silent infection. Treatment is azithromycin. For gonorrhea, the classic sign you're looking for is that yellow-green discharge, and we hit it with ceftriaxone. And then syphilis, the hallmark of the primary stage is that painless chancre, and the treatment is penicillin G, full stop.
All right, let's switch gears and move on to Section 4, Navigating Group B strep. We're shifting away from STIs now because GBS is a totally different kind of beast. For many adults, This bacteria is just part of their normal flora. But, and this is a huge but, it can be absolutely deadly for a newborn during the birthing process. It can cause neonatal sepsis, pneumonia, even meningitis. It is serious business.
So, the critical decision for you as the nurse is who gets antibiotics during labor. You have to know these criteria. We absolutely give antibiotics if the client has a positive GBS culture. That's a no-brainer. We also give them if their GBS status is unknown and they have risk factors like being preterm, having a fever, or if their water's been broken for more than 18 hours. Now, who doesn't get them? A client having a planned C-section with intact membranes, or anyone who had a negative culture during this pregnancy.
Okay, on to Section 5, Understanding Torch Infections. You're going to hear this acronym a lot in OB. These infections are all grouped together for one very scary reason. They are the placental pass-throughs. They have the ability to cross that protective barrier and cause serious harm to the developing fetus. So what does TORCH actually stand for? Let's break down the mnemonic. T is for Toxoplasmosis. O is for other infections, which includes things like syphilis, hepatitis, and varicella. R is for Rubella. C is for Cytomegalovirus, or CMV, and H is for Herpes simplex virus. If you remember one thing about this group, let it be this. They all cross the placenta and can cause serious birth defects.
Now, for many of these torch infections, prevention is our most powerful weapon, which means patient education is a huge part of your job. You'll be teaching about cooking meat thoroughly and avoiding cat litter to prevent toxoplasmosis. You'll have to explain why the Rubella vaccine is a no-go during pregnancy. It's a live virus, so we give it postpartum. And for HSV and CMV, it comes down to fundamentals like strict hand hygiene and using suppressive therapy for HSV to prevent an outbreak near delivery.
And here we are, Section 6, your Essential NCLEX Review. We have covered a ton of ground. Now it's time to boil it all down to the absolute must-know facts for your exam and, more importantly, for your practice. This is the stuff you've got to have locked in.
Let's do a rapid-fire review. Ready? First, know your reportable diseases: HIV, syphilis, gonorrhea, and chlamydia. Second, the syphilis rule. Penicillin G is the only answer. If they're allergic, you desensitize, you do not substitute. Third, metronidazole alert. If your patient is on this for trich or BV, the #1 teaching is to avoid alcohol. Fourth, yeast infections. We use topical antifungals. Oral fluconazole is contraindicated. And finally, the Rubella vaccine. It's a live virus, so it's a big no during pregnancy. We always give it postpartum.
I really want to double down on this penicillin G rule for syphilis because it's that important. You might think, well, what if my patient has a severe allergy? It doesn't matter. The consequences of untreated congenital syphilis are so devastating that the protocol is firm. We do not pick another antibiotic. We admit the client to the hospital and put them through a desensitization protocol so they can safely receive penicillin G. That's how critical it is.
Okay, I want you to remember one number: 12. Just the number 12. Because when a baby is born to a hepatitis B positive mother, a timer starts. We have just 12 hours to give that newborn two things: hepatitis B immune globulin, or HBIG, for immediate passive immunity, and their very first dose of the hepatitis B vaccine. It's an urgent two-pronged approach, and it's our best shot at preventing transmission.
So look, we've gone through all the timelines, the treatments, the tests, and yes, you absolutely need this for your exam. But I want you to think bigger. Mastering this material is what allows you to sit with a scared, anxious client and calmly explain why their treatment is so important. It's what makes you a powerful advocate, ensuring every patient gets timely screening. This knowledge isn't just about passing a test. It's about becoming the incredible nurse, advocate, and educator your patients deserve.